made few phantom models of the brain also. This is what information I have got in the past years by being his Facebook friend. So, and we had a good time 10 to 11, 12 years back. And we welcome you, Dr. Khurshid, and it's a pleasure to have you. Thank you. Over to you.
Thanks, Naveen, for the kind introduction, and thanks for having me to present today. This presentation is intentionally, I kept it basic, so my apology for people who find it too simple for them, because the philosophy of SCAN, as Dr. Thomas will explain tomorrow, is to keep it simple, because it starts with the question and then you build the skill based on the question, as compared to the traditional way of teaching is that you traditionally start to learn everything from get-go and spend a whole year on learning echocardiography or neuroimaging. So the purpose of cranial ultrasound scan is really diagnose big problem, whether there is IVH or no, if there is any major brain malformation or cystic PVL, you'll be able to diagnose that. So the first question we ask ourselves, which mode of imaging should we use to diagnose brain injury in premature infants? Because we are talking about brain injury in premature infants, not in HIE or stroke. And the two modalities we have here are MRI and cranial ultrasound. MRI is more specific, it's more predictive, and in a way it's becoming the new head ultrasound, giving the new type of injury that we are facing in premature infants. However, cranial ultrasound remains the most practical because you can do it repeatedly. You can do it even if the baby is sick. You need to take the baby to the MRI suite to do the MRI, and you cannot do it frequently. So oftentimes what we say, if you cannot explain the injury or there's something that you cannot interpret on the cranial ultrasound, the baby is stable enough, then we need to take the baby to the MRI. And the other indication for MRI is usually a term equivalent MRI for premature infants, because that's really a better way to predict the long-term outcome. But for the sonographic clinical assessment of the newborn, the cranial ultrasound is the way to go. The type of probes, I'm sure you will have lots of hands-on to differentiate between the types of probes. There are usually three types of probes. There you have the curvilinear, where the footprints of the probe is curved. And you have the linear probe, where the footprint is straight. And you have the phased array, the one that Dr. Gupta was showing you in the echocardiography. The curvilinear probe is the best for cranial ultrasound because it dives into the anterior fontanelle and it shows you bigger portion of the brain, as compared to the linear probe where you see part of the brain is cut off. We use the linear probe in cranial ultrasonography for the sinuses. So if you want to rule out CSVT, and also we use it for cerebellum. So if you want to rule out any cerebellar hemorrhage, you can use the linear probe. The difference between the curvilinear and the linear probe, the frequency is much higher in the linear probe. And that's why the quality of the images are better, but it is shallower. It can't go deep enough. Compared to the curvilinear, you can see the whole brain, but the quality of the image is not as good as the linear probe. The anatomy or the landmarks of anatomy and structure on cranial ultrasound is really built around the ventricles. If you want to understand the anatomy of the brain, we need to make ourselves really familiar with the boundaries and the borders of the lateral ventricles and third and fourth ventricles, because the whole brain is developed around the ventricles. So if there is any malformation or injury, whether it's acquired or congenital, the chances are there will be a signature on the ventricles. So if we build this normal library inside our brain about the anatomy and the borders of the lateral ventricles, any deviation from that normal library, it will trigger us that there is something wrong. And if it's something that we cannot interpret, at least we will call a friend. And that's one goal to achieve from the point of care ultrasound. So let's start with the boundaries of the lateral ventricles. The posterior horn of the lateral ventricle is surrounded by the white matter. And that's how this is the posterior horn of the lateral ventricles. You see the white matter here surrounding it. The anterior horn of the lateral ventricle is one of the most important structure, and the boundaries of this anterior horn of the lateral ventricle is very important. The roof of the anterior horn of the lateral ventricle is the genu of the corpus callosum. It's this thick band that you see here is the roof of the anterior horn of the lateral ventricle. The lateral boundaries of the anterior horn of the lateral ventricles are the head of the caudate, and that's important. These are MRI compared with the cranial ultrasound images. In between the anterior horns of the lateral ventricles, usually if you have a premature baby, you will get a triangular shaped structure called the cavum septum pellucidum. As the gestational age increases, this cavum septum pellucidum, the CSF inside it get absorbed and becomes septum pellucidum. So basically the septum pellucidum is a double-walled previous cavum septum pellucidum. The third ventricle, simple, really surrounded by the thalami. On both sides of the third ventricles are the thalami. You don't see the fornix, and you usually don't see the midbrain on the cranial ultrasound. All you see is the thalami on both sides of the third ventricle. And the last one really is the fourth ventricle, and it makes this faba bean shape because of the imprint of the vermis. So you have in the posterior part of the fourth ventricle is the vermis, and both sides on the lateral of the fourth ventricles are the cerebellar peduncles, and the anterior wall of the fourth ventricle is the pons, cerebellar peduncles, and the vermis. It makes this faba bean shape. Now, what are the minimum cuts when we perform the cranial ultrasound? With the coronal, you put your probes at the anterior fontanelle with the pointer to the right of the baby, and then you angulate with the tail going to the back of the baby, and the cut of the ultrasound beam slicing through the anterior part of the brain. And you stop when you start seeing the orbits. The portion of the brain that we are seeing is smaller because we are seeing the frontal portion of the brain only. And we see the interhemispheric fissure here. And then from there, this is the corresponding cartoon where you get your slice. From there, once we have our spot, we are happy with it. We don't rotate, we don't slide, we don't tilt. The only movement that we are doing is angulating posteriorly. So from here, we went one slice posterior. So we started to see the anterior horns of the lateral ventricles. And because this is a premature baby, remember we talked about the cavum septum pellucidum, this triangular shaped structure started to show up, and we see the interhemispheric fissure. We start to see the temporal lobes here, which are behind the orbits. So as we go posterior farther, now we see the full temporal lobes on both sides. We see the full cavum septum pellucidum, which is this triangular shape. We see the boundaries of the lateral ventricles. This is the genu of the corpus callosum, and these are both anterior horns of the lateral ventricles. The other landmark, which is very important at this level, are the sylvian fissures. At this level, we do all our ventricular measurements. And that's the level when you start to see the cerebellum. You don't see the full cerebellum, it's the starting of the cerebellum. You see the foramen Monro opening to the third ventricles, and you see the sylvian fissure. At this level, we do all the measurement, the ventricular index, the anterior horn width, and the frontal and temporal horn ratio. And we'll see in the later slides how we do these measurements. And I hope on the hands-on session also, you will get the chance to perform these measurements here or practice these measurements yourself. And now as we go posterior further, we start to cut through the choroid plexuses. And this is a place where people commonly mistake it for grade 1 IVH. The reason why this is not grade 1 IVH, there's 3 reasons for that. One, this is too symmetrical for IVH. Usually, even if you have bilateral grade 1 IVH, one of them will be bigger than the other, the echogenicity will be different, but this is too symmetrical to be IVH. The second is this is too posterior for the level of grade 1 IVH. Usually the grade 1 IVH is anterior to this level. And third, which is the most important, as you slice posteriorly, you will see that this is a continuation of the full choroid plexus. And at this level, we could still see the third ventricle, and we start to see the full cerebellum. And in this area is where the hippocampi sit. You cannot identify them clearly on the cranial ultrasound, but this is where anatomically they are located. And as we move farther posteriorly, now you can see the full length of the choroid plexus. These are the brightest structures in the brain. And you see the full body of the lateral ventricle, and you see the watershed area around the lateral ventricle. And then you continue. This will be your last slide when you lose the ventricles. We carry on until we lose the ventricles, and this will be our watershed area. And you see, as I was going posterior, now the tail is going toward the anterior part of the baby, and the slice is slicing through the posterior part of the brain. And this way you will be done the coronal sweep. Now, after this, we will come back to our starting point. The starting point, it should be at the level of foramen Monro, where the pointer is to the right of the baby and it's flat. And from then and only then, that's the only time we do a rotation. You rotate the probe where the pointer now is to the front of the baby. And we should be at the midline, and we should see the full length of the corpus callosum. We see the genio of the corpus callosum, the body of the corpus callosum, and the splenium of the corpus callosum. And this structure, the dark area inside the corpus callosum, when I ask people, lots of students, they say these are the lateral ventricles, which they are not. They are not, or they answer it as a third ventricle. The third ventricle is, in fact, inferior to this. This is at the level of the lateral ventricle. And because it's in the midline, it's either the cavum septum pellucidum or the septum pellucidum. At the sagittal view, you cannot differentiate between the cavum septum pellucidum or versus the septum pellucidum because you are looking through a transparent membrane. Whether it's one membrane or two membrane, you will see it similarly. The only way to differentiate between the cavum and the septum pellucidum is at the coronal plane. So this is the full length of the corpus callosum. Then below it is the impression of the third ventricle, and sometimes it creates a shape of head of a bird with a beak in this area, but it's not as clear here. And then you see this, the vermis of the cerebellum as well. Anterior to the vermis will be your fourth ventricle, and then anterior to the fourth ventricle will be the pons. And these are the landmarks that we see at the midline. And then from there, again, the only movement you will do is angulation. And now whether you go left and right, as long as you have a system that you follow it consistently, and at this level, you need to label the images, because at the coronal, because it's standard, it's a mirror image, I can kind of predict where is left and where is right. But on the sagittal and parasagittal, there is no way for the person who's reading the images offline to be able to identify left and right unless you have labeled them as left and right. So you follow the same system. In this case, we angulate it to the right, and this is the most important cut to identify the grading of IVH, whether it's grade 1 or grade 2 and grade 3. And the anatomical landmark is cordothalamic notch. So this is the caudate. Under the caudate and posterior to it is the thalamus. So you go cordothalamic notch, where the notch, where the caudate ends, the choroid plexus starts. And in this area, if you have a structure or any abnormality that's as bright as the choroid plexus, that will be grade 1 IVH, and we'll talk about it later. And we always check the posterior occipital horn as well, because by gravity, if you have IVH that you couldn't identify it here, the blood will create a layer in the occipital horn of the lateral ventricle. And then you continue until you lose the ventricles, and that's where you get our watershed area. And this is where the Sylvian fissure is. It creates this like a puppet or a mitten, where the thumb is here, and then the rest of the fingers are here, and you get your back of the hand in the occipital horn. So that's really it. When you do your cranial ultrasound, you get your cuts in the coronal and the sagittal. But how can we grade the intraventricular hemorrhage? So the common gradings that we have is the papille and the ball-based grading. But before that, I wanted to show you quickly this case. This was a 23 plus 6 weeks at birth. The mom received 1 dose of steroids. This was born at Foothills, delivered vaginally, intubated in the delivery room. The cord pH was 7.19. The admission temperature was borderline, 36.5. Baby had central lines. Baby had RDS, required surfactant, failed extubation, had CO2 fluctuation, and mixed acidosis. Now, the report of the cranial ultrasound at day 5 of life came as follows. Grade 4 IVH on the left, blood in the ventricles, no ventriculomegaly. Now, if you were the physician taking care of this baby, 23-weeker, still ventilated, day 5 of life, and only 1 dose of steroids, would you talk with the family about redirection of care? And when I ask this question at conferences, most of people, including myself, I will raise my hand and will say this is reasonable based on the report. However, if you look at these 7 images, they were rightly categorized and classified as grade 4 IVH because you have intraparenchymal hemorrhage here and you have intraparenchymal hemorrhage here. But clearly, the prognosis for this baby is very different than this baby. So the point I want to make here is when we are counseling the families, we need to be descriptive. We need to pull the images, we need to look at the images, and we need to put the images in the context of the case that we are dealing with. And this 23-weekers, in fact, ended up having completely normal outcome. And we approached this family several times, offering the redirection of care, but the mother was very reluctant, thankfully, and she didn't listen to us. But if you are using the ultrasound as an outcome measure to measure our intervention, whether it's for research or for QI, it's important to be consistent, and it's important to create a protocol and a consensus approach for the classification of brain injury in premature infant. And the reason why it's important, if you look at the papille classification, as you know, the papille classification, she had 4 grading. You have grade 1 IVH if it's located in the cordothalamic notch, and you have grade 2 IVH if the blood is filling less than 50% of the lateral ventricles, and it's grade 3 if it's filling more than 50% and the blood is distending the ventricles acutely. And you have grade 4 IVH if you have the periventricular hemorrhagic infarct. Then the Volpe came and he took some of the grade 2 IVH in the papille classification, and he made them as grade 1 IVH. He said if you have general matrix hemorrhage in the cordothalamic notch and blood in the ventricles, which is less than 10% of the size of the ventricles, we'll still call it grade 1 IVH. If it's more than 10% but less than 50% and the blood is not distending the ventricles, then we will call it grade 2 IVH. If it's more than 50% and blood is distending the ventricles, then we'll call it grade 3 IVH. And if you have a hemorrhagic infarct, that's a completely different entity. So you moved away from grade 4 IVH, said there is grade 1, grade 2, grade 3, but there is periventricular hemorrhagic infarct because the pathophysiology for that injury is completely different than the rest of the 3 grades. So clearly, as I will explain later, there's lots of areas of variability in this classification. So many people have tried to come up with more accurate classification for acute brain injury premature infant. And Calgary was one of the group who looked at the new scoring system developed by one of our ex-fellows, Samir Al-Abdi, and they found that this indeed was better in predicting the long-term outcome when compared to Papel and Volpe. However, it was too cumbersome to become practical and feasible for everybody to use at the bedside. So that's the conundrum. You can come up with a scoring system that's very predictive, but it's too complex and complicated that people are not using it. The reason why the SARNAT scoring, staging, the UPGAR score, the PAPIL classification, they are surviving all these years because everybody can use it. It's so easy that ease, that feasibility made it survive all these years. And all this fancy, complicated, complex scoring system that we are every year coming up with, it just doesn't survive because you can't use it at the bedside. So this variability is a reality. This paper on the left was published in 2001 out of the Canadian Neonatal Network. They looked at the incidence of severe brain injury across the centers in Canada, and they found there was a lot of variability in that incidence. They tried to control for all kinds of confounding factors, and that variability didn't go away. And similarly, the paper out of the INEO, and this is comparing the severe brain injury among several countries that are contributing to this network, and they found there was similar variability when it comes to the incidence of severe brain injury. So what we did here in Canada, we created a task force of radiologists, neonatologists, and neuroradiologists from all the level 3 centers in Canada. And we sat together over about 2 years through emails, through in-person meeting, through workshops, and we came up with a consensus classification that we have been using since. This paper is open access. You can download it, all the images and the apps are there. And what we did as a first step, we tried to identify the sources of variability for the diagnosis of acute brain injury in premature infants. And we found at least 5 sources of variability. The first source of variability was jumping to conclusion and making the grading classification diagnosis based on one cut and not looking at this other cut. And this is an example of 24-weeker where again at day 4 to 5, we did the cranial ultrasound and they found this clot here, and it was reported as grade 4 IVH. And this family again was approached for redirection of care because you have a 24-weeker twin ventilated day 4 of life with grade 4 IVH. But when we looked at the lateral or parasagittal cut, you can see that the clot is completely outside the parenchyma. It's in fact at the codothalamic notch. It's one of those large grade 1 IVH. However, there was a layer of blood also in the occipital horn, so that's made it grade 2 IVH. So from grade 4 or periventricular hemorrhagic infarct to grade 2 IVH is a big, big difference. So always confirm the abnormality with the other cut. So that was the first source of variation that we had. The second, and this was the MRI later, when we did the MRI, indeed, it confirmed that it was that big grade 1 IVH. And this is because in micropremies, the germinal matrix is not only covering the caudate, it's covering almost most of the lateral ventricles. So you got this misleading posterior grade 1 IVH that it can be mistaken for grade 4 IVH. And this is the T1 sagittal view where blood is bright. You see only this is what remained from that grade 1 IVH, a tiny hemorrhage in this area. The second source of variation was echogenicity. What is significant echogenicity for you might not be for me. What's too bright for you might not be too bright for me, and vice versa. And this was an example of a late preterm baby who presented with seizure. The baby wasn't stable enough to go for MRI, so we did a bedside ultrasound, and it showed this area of echogenicity. This was reported as intraparenchymal hemorrhage by the radiologist. And then the next day, we were able to send the baby to MRI. This is a T2 weighted image where the CSF is white, and the blood should be black. And the same area, you can see there is no darkness in this area. Rather, there is this absence of the gray-white matter differentiation. If you compare the left to the right, in the left you can make out the cortex from the white matter, and like the right side. And this area, in fact, was edema. It wasn't hemorrhage. So how can we differentiate between edema and hemorrhage or ischemia in the on the cranial ultrasound? Cranial ultrasound is notoriously bad in diagnosing ischemic injuries. It's good for hemorrhagic injuries. It's good for cystic lesions, but not for echogenic lesions. So what we did as a consensus, we agreed to use the choroid plexus brightness of the same baby as a reference. So if the injury or the echogenicity that you are seeing is brighter than the choroid plexus, we will call it significant. And then the second step is we ask ourselves, is there germinal matrix hemorrhage? So if you have significant echogenicity, which means it's brighter than the choroid plexus, and there is germinal matrix hemorrhage, then we call it intraparenchymal hemorrhage or periventricular hemorrhagic infarct. If there is significant echogenicity, the lesion is brighter than the choroid plexus, but there is no germinal matrix hemorrhage, then we will call it significant white matter injury. And these are an example as classic grade 4 IVH, what used to be called grade 4 IVH, we call it now periventricular hemorrhagic infarct. And then eventually this periventricular hemorrhagic infarct will leave a big porencephalic cyst. It's another example of a porencephalic cyst. Now, and this is an example of echogenicity, significant echogenicity without any hemorrhage in the ventricles, and eventually on the MRI, you see the lack of myelination. Myelination on T2 weighted image is dark, so this area of white matter, it has been myelinated appropriately, unlike the periventricular area where there is a lack of myelination due to this significant white matter injury. And these are the gradings of the cystic PVL, and this was published by Dr. Linda De Vries, which we agreed to follow. And grade 1 is when you have persistent significant echogenicity 1 week apart. And then you have grade 2 where you have periventricular echogenicity has resolved into small periventricular cyst, very small periventricular cyst. Grade 3, where there is extensive periventricular cyst in the occipital and frontoparietal region. Grade 4, when you have periventricular echogenicity in the deep white matter into extensive subcortical cystic lesions. And then the third source of variation was the differentiation between grade 2 and grade 4, because when they say grade 2 is less than 50% of the ventricles, the blood is filling less than 50% of the size of the ventricle. The question came up as 50% of what ventricle? Normal sized ventricle or dilated ventricle? And 50% we are measuring it in a 2D cut, where in reality is a 3D shape ventricles. So that was the problem. The other problem was If you had a grade 2 IVH like this one, where you have the cotothalamic notch and then the brightness is anterior to the cotothalamic notch, and you did this at day 5 of life, and then at day 14, you repeated this ultrasound, and now the ventricles are dilated. Would you call it still grade 2 IVH with post-hemorrhagic ventricular dilatation secondary to grade 2 IVH, or will you upgrade it to grade 3 IVH? We found lots of confusion and variability in that. Some radiologists will upgrade the grade to grade 3, and some of them will say, no, this was grade 2, and this is a complication of grade 2. So to solve this problem, one, to differentiate between grade 3, which this is classic grade 3, the whole ventricle is filled with the blood and the blood is distending the ventricles, and grade 2, how can we differentiate between the two of them? We decided to go with the anterior horn width measurements. If you have blood in the ventricles in the first 7 days of life, and the anterior horn width is more than 6 millimeters, you will call it grade 3 IVH. If you have blood in the ventricles and the anterior horn width is less than 6 millimeters, we will call it grade 2 IVH. And then the second, we decided to have the first 7 days of life, we call it the grading image. So the worst grading you have in the first 7 days of life is your grading. You do not change the grade after 7 days of life, unless it's completely new entity. Whatever happens after the day 7 of life is a complication of the initial insult, because we know most of the IVH happens in the first 7 days of life, in the first 72 hours of life. So whatever happens after that, we had a 7-day to have a buffer and a window. Whatever happens after 7 days is a complication of the initial grade. So that's the sources of variation. And just one word about the hydrocephalus or post-hemorrhagic ventricular dilatation. If you have a large ventricles, the second question we ask ourselves is the head circumference. If the head circumference is large, we are dealing with hydrocephalus. And then once we identify this hydrocephalus, then we need to decide, is the obstruction is intraventricular or is extraventricular. You look at the subarachnoid space. If it's obliterated, you are dealing with intraventricular hydrocephalus. If the subarachnoid space is normal or increased, we are dealing with extraventricular hydrocephalus. This is what it used to be called communicated and non-communicated hydrocephalus. We are moving away from that term because it's always obstructive. It's either intraventricular or extraventricular obstruction. If the head, you have large ventricles and the head small or normal, then we are dealing with malformation or atrophy. And there are 6 steps that you can follow to identify the brain malformation, which we won't have time today to go over it, and it's out of the scope of the scan. Now, a few words on hydrocephalus. We, as you know, we have 2 schools. We have the neurosurgery school, where we think they intervene late, and we have the neonatology approach, which I think is too aggressive, and the truth lies somewhere in between. But for the purpose of today's talk, which indices should we follow and where to measure those indices? So one of the things we did here in Calgary, we asked one of our fellows and one of our neuroradiologists and one of our neonatologists with the training in neurology is to measure the whole cohort that we had for IVH prevention bundle, which was about 600 babies with many, many ultrasound. And we asked them to compare 3 indices. This was the most common indices that we used to measure the ventricles. There was the anterior horn width, the ventricular index, and the frontal and temporal horn ratio. What we found that the most predictive and the best intra-observer reliability was the ventricular index and the anterior horn width. With the advantage of anterior horn width over the ventricular index, that it's a cutoff. You don't need a graph to plot it against the gestational age as compared to the ventricular index. So right now in our unit, we do the anterior horn width to guide our management for hydrocephalus, but we do report both ventricular index and anterior horn width. How to measure the anterior horn width and how to measure the ventricular index? First of all, we pick our cut. And if you remember, we said that when you start to see the cerebellum, you see the Sylvian fissure, and it should be at the level of foramen Monroe, where it opens to the third ventricle. So you go from the deepest point to the midline, and that will be your ventricular index. And one of the tricks that our neuroradiologist taught us, if you draw a guided line at the level of the deepest point, then it doesn't matter from where you draw your line, you'll get the same measurement. And for the anterior horn width, it's really the widest width of this shape, and usually go midway from inside to inside. And again, one of the trick that he taught us is if you draw a guided line through the roof of the third ventricle, and then you draw the perpendicular line on top of that, and then you get your anterior horn width. It gets easier when the ventricles are dilated. It gets very tricky when the ventricles are not dilated. But that doesn't matter because your anterior horn width will be below 3 millimeters anyway. So below 3 millimeters normal, between 3 and 6 is mild, 6 to 10 is moderate, above 10 severe post-hemorrhagic ventricular dilatation. These are the definition of post-hemorrhagic ventricular dilatation that we agreed on in that consensus paper. And this is the paper where they compared all the indices that I mentioned. This is one of the approaches, how frequent you do the ultrasound. And it was interesting because we had some co-authors from Europe and some co-authors from Canada. The European co-authors, they thought we are doing too few ultrasounds. And the North American authors, they thought we are doing too many ultrasound. And there was this interesting debate between the two schools until we found a common ground of how many ultrasound you need to do. If the ultrasound is normal, you do one a day 4 to 7, then you do one a day second 4 to 6 weeks, and then you do one at 36 weeks. And if it's abnormal, depending on the abnormality, you increase the frequency of the ultrasound imaging. So this is the diagnostic app. I'm happy to share the slides with you. You can download it. It's free. It goes through the asking you questions, and when you answer the question, there will be pop-up images showcase the grading of the IPH related to that question. At the end, it will give you the diagnosis. And this is the modules that you can go through it online. And this is where we make all those phantoms and simulators. This is Norma. She makes it in her kitchen. And this is our computer scientist who makes all the programs and add cases to our computer-based simulators. Thank you very much.
Thank you, Khorshid, for such a comprehensive and a nice presentation, and many eye-opening and many nice tricky points you mentioned in this thing. Like many of us were very new to, at least to me. So I hope the delegates have a very good learning, and it will be wonderful if all the participants, they can have few questions for you.
Yeah, happy to take questions.
Yeah, so Dr. Sakir is asking, excellent presentation. Could you explain about the probe frequency in head ultrasound, difference between tilting, sweeping, and rotation?
That's Sakir should be the master on this. Anyway, the probe frequencies, the higher the frequency, the better the images, but the shallower the depth is. And the lower the frequency, the more deep you can go, but the less the quality. The happy medium for cranial ultrasound usually 6 to 8, the frequency. You can increase and decrease it because nowadays probes, they are multi-frequency probes. So you can change the frequency until you are happy with the images. And that's with the curvilinear. You can still use the phased array for cranial ultrasound. With the linear probe, the frequency is 8 to 12 sometimes, and it doesn't go deep enough, but it's excellent for the sinuses. For example, I use it a lot in term babies when you have an HIE on cooling, and neurologists, they want to rule out CSVT. They want to send the baby to MRI. And if you send the baby to MRI, you will disrupt the cooling. So we are able to do the ultrasound and show them that the sinuses are patent. So there is no urgency to do the ultrasound. They agree to keep it until after the cooling is done. And also we use it at the mastoid window to look at the cerebellum. Now the movement, and I don't know if you can see my hand, the rotation is like this. You rotate. And then tilting, if this is the cranial ultrasound, the tilting is sideways. So you go sideways, you see the image tilt. When the image is dancing, when you are moving the probe, that's tilting. And then sliding, if you are not at the anterior fontanelle, then you have to slide the probe to put it inside the anterior fontanelle. You will see portion of your images is not showing because it's going through the bone, and another portion is showing. As you slide back into the anterior fontanelle, you see the full size of the brain showing up. And angulation is where you angulate. So now I'm creating an angle. The tail of the probe is going posterior and the head of the probe is going anterior, or vice versa. The tail is going anterior and the head is going posterior. So that's angulation. This is tilting, this is angulation, this is rotation, and this is sliding. The whole probe is sliding.
Okay. Thank you. Another question is from Dr. Ashish Jain, who is the head of Department of Neonatology at a very prestigious Maulana Azad Medical College. So, sir is asking, the confusion for hyperechogenicity is query bleed, white matter injury, or infarcts. How will we differentiate? Little bit you touched upon, and you can explain it. How to suspect infants, especially in the preterms with perinatal asphyxia? This is the first question.
Yeah, so a very good question, actually. This is hyperechogenicity. In essence, white matter injury without bleed, germinal matrix hemorrhage, is infarct. So those are two the same thing. So you have, unless you have a classic big vessel infarct, you have like MCA infarct or AC infarct, that is different. And for that, we will need an MRI to confirm that. But if we are talking about a smaller infarct, white matter injury type infarct without germinal matrix, so the starting point is looking at the echogenicity. Is the echogenicity significant or not? Is the brightness is brighter than the choroid plexus or not? So if that's yes, then the second we'll look at the germinal matrix. Is there IVH or germinal matrix hemorrhage? If we have IVH and germinal matrix hemorrhage, then that brightness become bleed. If we don't have germinal matrix hemorrhage or IVH, then that brightness become white matter injury or stroke if it's located in the territory of one big artery or vessels. And perinatal asphyxia, it's harder question. Usually, and that's, again, this is my opinion, it's not evidence-based, the pattern of injury in the preterm baby, especially extreme preterm baby, when they have perinatal asphyxia, is hemorrhagic. And that's why once you drop your cooling criteria below 35-week gestational age, you start to see complication from cooling in the form of hemorrhage in these babies. And that's when you look at, in fact, the HELOX trial, there are lots of hemorrhages and white matter injury in these the babies because they had more SGAs and they had more partial bronch asphyxia pattern of injury there. So if you have perinatal asphyxia that we couldn't identify with the cranial ultrasound and make the diagnosis, because the cranial ultrasound is just notorious when it comes to echogenicity. You cannot differentiate well between hemorrhage and asphyxia and stroke. And there when the MRI become important that we need to do MRI. One clue sometimes you have this patchy echogenicity in the cranial ultrasound. When you put it in the context of the history, that can be a clue that this is asphyxia injury. Now the other question, there's no situation with anterior horn with less than 6 and significant increase in VI. Usually it could be, but usually you get the anterior horn with increment before the ventricular index, because it's the true measurements of the ventricular size. It's measuring the actual ventricles. With the ventricular index, you are coming outside the ventricles and you're going through to the intrahemispheric fissure. What we found, both of them were equally predictive, but the anterior horn width was simpler. And the reason why we picked 6 millimeters, when we did the ROC curve, those babies who had the anterior horn width below 5.8 millimeters, none of them required surgical intervention. So we bumped it to 6 to make it easier to remember and also to increase the sensitivity. And that's where the 6 millimeter came up with. And also, people are used to 6 millimeters because of the definition of post-hemorrhagic ventricular dilatation. Later on, it goes with 3 millimeters, 6 millimeters, and 10 millimeters.
Great. Thank you, Khurshid. Another question from Dr. Ashish is, we in India usually do not use FTHR. FTHR is, I think, high frequency probe.
No,
Is
FTHR is the frontal and temporal horn ratio. I'm glad you are
okay.
not.
Yeah.
So what we
Yeah.
did in that paper that we published, we found that the frontal and temporal horn ratio, it was the least accurate. The most inter-rater variability was in the frontal temporal horn ratio as compared to ventricular index and anterior horn width, because it's tough to identify the borders of the temporal horns. It's not as easy as the anterior horn. But the neurosurgeons, they love it. They love the frontal temporal horn ratio and the frontal and occipital horn ratio, which that paper was based on MRI and CT scan. It wasn't based on cranial ultrasound, because with cranial ultrasound, as you know, you don't have a true axial and you don't have true coronal. It's because the angle is oblique, you get a combination between the coronal and the axial. And that's why the paper was published where they showed the frontal and temporal horn ratio correlated very well with the frontal occipital horn ratio, and it got replaced with that. Thalamocortical distance, yeah, it can. Again, it goes the same problem with it is the identification of the starting point of the line, which will be your thalamus, and sometimes it get obliterated by the choroid plexus itself. So it's hard to identify the border of the thalamus. And similarly, the bottom of the occipital horn, if you have blood, if you have the angle is not right, you can easily overestimate or underestimate hydrocephalus. So that's where we found that it wasn't as accurate as the anterior horn width or the ventricular index.
Yeah. I think. Yeah. Thank you. So, Khurshid, I think there are no more questions. Thank you so much, and it was a pleasure to have you here in India. And we hope that in other presentations also, we will be inviting you very often. Thank you
No
so
problem.
much.
Thanks. It was so nice seeing you, Naveen, and all the best. Thanks, everyone. Bye.
Thank you. Bye. Bye. Thanks a lot. Okay. So, I think it's time that we should now do the next presentation. And
Yeah.
the next presentation is on lung ultrasound. So, sir, I will start it.
Just Naveen,
Yeah.
because you had a long run, I think you might need a little bit of rest. Do you think that you can do lung after the lines, or how would it work?
Either way, sir, I will do first lung and then line. Either way, sir, no
Yeah,
worries.
just check with
I will
Sumesh
do
if
that.
he's ready.
Yeah.
Sumesh,
So in the morning, I had a chat with Sumesh. The place where he is, the network is a little bit problem on the laptop.
okay,
That is why he has connected through the phone.
okay,
So I think I will, right in between, there was a 45 minutes rest. So I will speak both of them, sir. No worries.
sure, okay.
I will do. Right. Thank you. I will. Okay. So, Okay. So, yeah. So coming to lung ultrasound. So one of the things which Dr. Srinivas said, that it was initially thought that it will be really, really difficult, that lung, because we will not be able to see it through ultrasound, or we will